Assalamu alaikum and good afternoon everyone. In this video, we will keep discussing about benzodiazepines and barbiturates along with Z compounds and buspirone. So let's get right into it. In my previous video, I discussed about GABA A type of drugs, that is benzodiazepines and barbiturates. Although ethanol or alcohol is also a GABA A type of drug, but it's not a part of our discussion today. I will discuss it separately in my upcoming videos. So keep watching. There are three types of GABA receptors. GABA A receptor is a ligand-gated ion channel, and it is also known as ionotropic receptor. Its main locations are thalamus, midbrain, the region of ascending reticular formation, and limbic system, most important. And amygdala is the main region of it. GABA B receptor is a G protein coupled receptor, and it is known as metabotropic receptor. It is mainly found in muscles. GABA C receptor is again a ligand gated ion channel, and it is now classified as a subtype of GABA A receptor. It is found in retina, meaning in eye region. Benzodiazepines are formed by the fusion of benzene ring with 7-membered diazepine ring. Benzodiazepines have an attachment site at the interface of alpha and gamma subunit, more specifically at the interface of alpha 1 and gamma 2 subunit. Benzodiazepines do not induce the opening of chloride channel as directly as GABA. Instead, the binding of benzodiazepines to their receptor site increases the affinity of GABA for the GABA binding site. This leads to increased frequency of chloride channel opening and hyperpolarization, making it more difficult for the excitatory inputs to cause action potential. So when the excitatory signals caused by stress or anxiety are inhibited in this way, the result is decreased anxiety and greater feeling of calm. The agents included in this category are alprazolam, clonazepam, lorazepam, chlordiazepoxide, diazepam, temazepam. Now the side effects of benzodiazepines are usually hooked up with their sedative and muscle relaxant properties, and they include sedation, ataxia, confusion, dizziness, lack of concentration, and impairment of motor and muscle coordination. Benzodiazepines are classified not on the basis of their structure, but they are classified on the basis of their duration of action. So here we have a classification of benzodiazepines. Benzodiazepines are usually long-acting, intermediate-acting, and short-acting agents. Long-acting agents include clorazepate, chlordiazepoxide, diazepam, lorazepam, clozapam. Intermediate-acting agents include istazolam, lorazepam, temazepam. Short-acting agents include alprazolam, midazolam, oxazepam, and trazolam. We usually prescribe short-acting benzodiazepines for the treatment of insomnias, and we prescribe intermediate to long-acting benzodiazepines for anxiety, for the relief of anxiety. So let's talk about the clinical uses of benzodiazepines. Benzodiazepines are sedative, hypnotic, and anxiolytic agents, so their primary use is in insomnia and anxiety. They are also useful in conditions like panic disorders and phobias. They are muscle hypertonic agents and useful in causing muscle relaxation in conditions like multiple sclerosis, cerebral palsy, etc. So they are useful in spastic conditions, basically. They are also good anticonvulsant agents and are initial best therapy in status epilepticus. Lorazepam, diazepam are the preferred agent. They can also cause anterograde amnesia, and this is needed in times of surgeries. They are used as an adjunct to anesthetics. These agents are also useful to control withdrawal symptoms caused by ethanol or alcohol. Barbiturates are the oldest sedative hypnotic agents. They are non-selective CNS depressant agents. They are derived from barbituric acid. They prolong GABA. They have attachment sites on the alpha and beta subunits of the GABA A receptor, and by doing so, they increases the duration of chloride ion channel opening with greater influx of chloride ion inside the neurons and result in hyperpolarization. They can also inhibit glutaminergic transmission by inhibiting glutamate AMPA receptors present on the postjunctional membranes. At high doses, they inhibit sodium channels and exerts their membrane stabilizing effect. That is the action they require while doing their or exerting their anesthetic action. At high doses, they also mimics the actions of GABA. That means they do not require GABA anymore to open the chloride channel. They can do it all by themselves. The agents include pentobarbital, phenobarbital, secobarbital. Barbiturates are very lipid soluble agents and have very little margin of safety, very narrow margin of safety. And we usually require very close monitoring of the dose because these agents can cause respiratory depression in slight overdose situations. Adverse effects includes all the effects of CNS depression, including confusion, dizziness, headache, ataxia, vertigo, you name it, coma, convulsions, respiratory depression, and death finally. These agents causes intermittent porphyrias, acute intermittent porphyrias, by inducing the enzyme ALA synthase or ALA synthase, which induces porphyrins. So they are contraindicated in porphyrias. These agents are inducers of P450 enzyme system of the liver. They have the dependence and addiction problems as well. They can cause physical dependence, they can cause psychological dependence as well. I will elaborate both of these in my next slides. Barbiturates are classified into long-acting and short-acting agents. Long-acting agents includes phenobarbital, while short-acting agents includes pentobarbital, secobarbital, and amobarbital. We have one more agent that is included in the ultra-short-acting category, that is thiopental sodium. Clinical uses of barbiturates includes obviously sedation and hypnosis, but as it is a very toxic group of agents and have very high lipid solubility, so very close monitoring is required, and in slight overdose situation it can cause respiratory depression. So we usually do not prescribe it now for sedation or hypnosis. Its use is in epilepsy. It is a part of the regimen of status epilepticus, generalized tonic-clonic seizures, and other epilepsies as well. So it is used even today as an anticonvulsant agent. It is also a part of anesthetic regimens. You also prescribe it for neonatal jaundice, as it induces glucuronide transferase, enzyme needed for conjugation, and it increases bilirubin metabolism. So now let's talk about tolerance and dependence. Chronic use of these agents leads to tolerance. Cross tolerance occurs between benzodiazepines, barbiturates, and ethanol. Now let's talk about dependence, which is of two types: physical dependence and psychological dependence. Physical dependence is more like abstinence syndrome, and it resembles CNS stimulation. So your patient could have all of the symptoms of withdrawal or CNS stimulation, which includes headache, agitation, ataxia, rebound insomnia, worse anxiety, and seizures if he or she is taking benzodiazepines for the relief of his or her epilepsy. Whereas psychological dependence is more like craving. I think it's the best time to discuss about flumazenil now. Flumazenil is a non-selective competitive antagonist at GABA A receptors and can block many of the actions of benzodiazepines and Z compounds, which includes zolpidem, zaleplons, and azipiclons. Remember, flumazenil cannot antagonize the effects of barbiturates, ethanol, and anesthetics. It can reverse sedative and hypnotic effects of benzodiazepines and Z compounds. It's used to reverse or antagonize the effects of benzodiazepine-induced respiratory depression is very unpredictable and requires adequate respiratory support if needs to be given. Flumazenil can cause agitation, dizziness, confusion, nausea, and seizures as well. Flomazanil can cause abstinence syndrome in patients who have developed psychological benzodiazepine dependence. So now let's switch gears and talk about Z compounds. Z compounds are non-benzodiazepine group of sedative hypnotic agents. They are structurally unrelated to benzodiazepines, but have attachment sites very near or adjacent to benzodiazepines attachment sites on the GABA A receptor. They have a relative selectivity for alpha-1 subunit on GABA A receptor, and after attaching with their respective subunit, they opens chloride ion channel for a longer period and allows chloride ions to get inside, allows more larger chloride influx with resultant hyperpolarization and CNS depression. These agents include zolpidem, zaleplons, and azopiclone. These agents have a lesser profile of side effects as compared to benzodiazepines, barbiturates, and ethanol. They are only useful for insomnias. They are devoid of any anxiolytic, muscle relaxant, and anticonvulsant activities. As they are useful for insomnia, so in toxic doses, they could give side effects of CNS depression, like confusions, drowsiness, headache, ataxia, lack of alertness, inability to concentrate. They also have less dependence problems, physical and psychological, as compared to benzodiazepines and other sedative hypnotic agents. So now let's talk about buspirone. Buspirone is not a GABA type of drug. It has an impact on the serotonergic transmission, and it's a partial agonist at 5-HT1A receptors. So it's a known partial agonist at 5-HT1 receptor, and as you know, partial agonist has duality of effects. On the one hand, partial agonist is obviously a stimulant, but on the other hand, in presence of a full agonist, it behaves like a blocker. So you can imagine it is clinically useful for generalized anxiety disorders. If your patient is anxious and too much agitated, you need to give your patient some depressant. So when you give depressant to your patient, and if he or she develops too much depression, so he would be expecting or needing some stimulant as well. So buspirone is a very good agent which balances the stimulant and the CNS depressant. The patient would neither be too depressive or too much excited. So it is a very nice agent. It gives its effects, shows up its effects in around 1 to 2 weeks, and buspirone is devoid of any sedating effect as well, so it's not useful for insomnia. It is just useful for generalized anxiety disorders and panic disorders. So adverse effects includes nausea, dizziness, nervousness, headache, blurred visions. It do not cause dependence, nor cause the sedation and motor incoordination, which is very important, which is usually seen with benzodiazepines and newer agents like Z compounds. So by this, I want to thank you all for watching this video. I hope you would like it and learn from it as well. Thanks a lot.